record. Okay, so that should put you, there you are. So I'm going to introduce you. I'm going to do a spiel about Share, and then I'll do a little spiel about you.
Awesome.
Not a huge thing, but hello and welcome to the program. And asking Dr. Puja Venkat about radiation treatments. I'm Corby, the uterine cancer patient support coordinator at Share. And I want to tell you a little bit more about Share. Share is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms. Because no one should have to face breast, ovarian, uterine, cervical, metastatic breast, ovarian, uterine, cervical cancers alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. Hoping and everybody needs to mute themselves, which you did. Thank you so much. Once Dr. Venkat finishes presenting, we'll begin the question and answer discussion. So feel free to ask any questions through the section at the bottom of the screen. Okay. So that would be in the chat, I guess. And then and remember that Dr. Venkat is unable to give specific medical advice, so please keep your questions general in nature, and I will ask all questions directly to Dr. Venkat. This presentation is being recorded and will be available on Share. I don't know how long, and then after about an hour, we'll have our newly diagnosed and inpatient support program. So Dr. Venkat is my doctor. She's my radiologist, and she's at UCLA, and she's also a professor. So she teaches other doctors, or future doctors. And so go ahead, Puja, go ahead, introduce yourself. I put my hat on you.
Thank you. It is my pleasure to be here. I feel very honored to have so many women here listening to me at this time of the night for many of you. I am a radiation oncologist at UCLA. I specialize in GYN malignancies and particularly brachytherapy. I thought a lot about how to formulate this talk, and based on my interactions with my patients, I realized my patients know a lot. So I'm not gonna sit here and lecture you with the basics. I'm gonna jump right in and talk to you like I talk to my colleagues and the residents I train. So this is an adaptation of one of the talks I give to our resident physicians on endometrial cancer. And I kind of like to think about medicine through my patients and through cases. That's how I learn. That's how I remember. So that's how we're going to frame this talk. I do have all your questions here. Many of them are not answered in this talk, but I promise to get to all of them. Okay, so let's just jump right in. And I also am happy to take any questions as we go along, or if you chat them to the group, I will see those. And I will keep my chat open to pay attention to that. So we're going to jump right into case number 1. We're going to start with a 70-year-old woman who presents with postmenopausal bleeding. This is, of course, how many women with endometrial cancer present to the doctors. So when we see this, what do we do next? What's our workup? First, we start with a history and physical, and we have to assess the amount of bleeding, if there's any pain, dizziness. When I wrote here orthostasis, that means your blood pressure drops when you stand up from a sitting or lying down position, which is a sign of not enough blood in the body due to bleeding. We also, of course, do a GYN exam. This is critical and unfortunately is often missed by our primary care and emergency medicine physicians. So I encourage all women to demand a GYN exam when they have GYN symptoms. So what am I looking at when I do an exam? I look at the whole external genitalia. That includes the vulva, the skin in the groins, the entire area. I look at the vaginal walls. I look at the cervix, the cervical os, which is the opening from the cervix into the uterus. And then of course we assess the uterus as well. In this case, there is no lesion visualized or palpated, so I couldn't feel or see anything abnormal. So what do I do next? This is typically not the radiation oncologist, so this would be more the GYN doctor. What would they do next in this setting? They would do a pelvic ultrasound to assess the thickness of the endometrial stripe. That's the area right in the middle of the uterus. If it's over 3 to 5 millimeters, that is a sign that maybe there's something abnormal going on. And what would be our next step? That would be an endometrial biopsy. So a very, very effective test to assess for cancer in the uterus, 95% sensitivity. So it doesn't get much better than that. But for those 5% of patients, when that biopsy is negative, is that the end of it? Do we just say, oh, well, you don't have cancer? No, you cannot just assume that. You must proceed with a D&C, which is more invasive surgical procedure to really get up inside the uterus and get more tissue out to make sure there's no cancer there. What histology do we expect? By histology, I mean, what do the cancer cells look like under the microscope? Where do these cancer cells come from? For 75 to 80% of women, endometrial cancers look like endometrial adenocarcinomas. Those are the most common type of uterine cancers, very common to the whole GYN tract. In fact, the ovaries, fallopian tubes, and the uterus are often endometrial adenocarcinomas. Unfortunately, we do have 10 to 15% uterine papillary serous carcinomas or clear cell carcinomas. These are more aggressive and harder to treat, and they do account for the majority of deaths from endometrial cancer. Our techniques and treatments have gotten better, but these are still a challenge for us. And even less common are sarcomas. About 3 to 7% of our cancers are sarcomas. We have carcinosarcomas, endometrial stromal sarcomas, and leiomyosarcomas. I'm not going to talk too much about uterine sarcomas today because that is a whole separate talk. Moving on. So for this woman, remember she was a 70-year-old who presented with postmenopausal bleeding. We proceeded with an endometrial biopsy, and we found a grade 2 endometrioid adenocarcinoma. So that, as I mentioned before, is the most common type of endometrial cancer. But what does a grade 2 mean? The options are grade 1, 2, and 3. Grade 1 is the most benign, the least aggressive type of cancer. And that's really a pathologist is looking at the cells under the microscope and looking for features of aggression. And grade 1 is not aggressive. Grade 2 is intermediate, and grade 3, the cancer cells are looking very, very aggressive. One way I like to think about that is when cancer cells start, they tend to be less aggressive and they look like the cell that they arose from. So they look like uterine cells with glandular definition, because uterine cells have a lot of glands. Over time, those cells become more aggressive and they become more de-differentiated. They don't look like those glandular cells that they started with, they don't really look like endometrioid adenocarcinomas. So that's what this lady has. What else do we want to know? We want to know many things. I'm going to start with some lab tests. I'm going to do a CBC, a CMP. Oh, now I'm just saying words that you might not know. I'm going to check your blood counts, your white cells, red cells, and platelets. I'm going to check your metabolic panel, check your kidney and liver function. The CA-125 is a cancer marker that we often check. It's not a great cancer marker. It sometimes is effective for some women, other times it's not. It's not as specific as we would want it to be, but it's something we tend to look at. And then of course, not in this case, but if someone is younger, we would want to do a pregnancy test before proceeding with imaging. And what imaging do I want? I want to assess the whole body for cancer. So typically what we would do would be a CT, chest, abdomen, pelvis is very common. You can do an MRI pelvis if you want to get a better sense of the soft tissue anatomy in the pelvis before proceeding with treatment. You could do a chest x-ray for the chest instead of a CT scan, but I personally don't think those are particularly effective. And I think that's more of an old school technology. I think you should probably just get a CT chest and really look at those lungs just to make sure nothing has spread to that area. If there are symptoms that are affecting the bladder or bowel, you do need to assess whether the uterine tumor has invaded those organs. The old school way that is still recommended by some is to actually do a cystoscopy where you look into the bladder, or a proctosigmoidoscopy where you look into the rectum and sigmoid colon. You actually look with your eyes, or a camera. One alternative to that is to just do an MRI pelvis. Those tests are amazing now. You can really see most of what you need to see with those, and tends to be a little easier. I am just going to take one break. They are messaging me to do a procedure, and I'm just going to ask if someone else can do it. 1 second. So sorry. I almost got everything done before 4, but couldn't quite do it. So in this case, all the studies are negative. The blood tests were normal. The imaging looked fine. So what is the patient's stage? That's really where we start as radiation oncologists. What's the pathology? What's the stage? This is actually a trick question because we have not staged the patient, because for endometrial cancer, there is only one way to stage the patient, and that is through surgery. So surgery is not only to treat uterine cancer, it's also to stage uterine cancer. One more message. Okay, so what's the next step? So the next step is actually surgical management. And what surgery do I recommend? It's pretty standard surgery of a total abdominal hysterectomy and bilateral salpingo-oophorectomy with pelvic and periaortic lymph node dissection bilaterally. These are just listed here, some of the regional nodes that we assess and take out, and a little bit more of what we do during the surgery. But the main point here is we take out the uterus. We take out the bilateral fallopian tubes and the bilateral ovaries. You also take just a little bit of the top of the vagina. And of course, you definitely need to take that cervix as well. And you also have to assess the lymph nodes on both sides of the pelvis, not just the pelvic lymph nodes. We actually want to assess a little higher into that periaortic region right above the pelvic inlet. So that's all really important. And that is going to give us our surgical pathology and help us stage the tumor and also decide what, if anything, to do next. So what do I look for on surgical pathology? We look at a lot of different things. We're looking at the histology. By that, I mean, what type of cancer is this? Is it an adenocarcinoma? Is it a clear cell? Is it a serous? The grade, like I mentioned, grade 1, 2, or 3. Very important for uterine cancers. I'm looking at the depth of the myometrial invasion. What does that mean? The cancers start at the middle of the uterus, and then they grow out through the uterine wall, or the myometria. That percentage of invasion helps us stage tumors. And also, if that tumor spreads outside all the way to the lining of the uterine wall, or the serosa, that's going to upstage the tumor. Or if it even gets outside of that uterus, that of course is going to upstage it even more. So that percent of myometrial invasion is important. LVSI means lymphovascular space invasion, which is a challenging thing to understand. I'm going to try to explain it in a way that makes sense to me. When cancers first develop, they don't have lymphovascular space invasion. That is a feature they develop over time, and it means it learns how to invade into the lymphovascular, the lymph node space, or the vascular space, the blood vessels, the arteries, and veins. So it learns how to invade into those spaces. It doesn't mean it has, it means it has the ability to. So that is a risk factor, and that does make us just think a little bit more about where this cancer might spread to or come back. I also need to know if the cervix is involved, as that upstages the tumor if it comes down into the cervix. Of course, we need our margins to be negative. I'm looking for disease in the lymph nodes. Size of the tumor is actually not that relevant. It's not part of the staging, but it's definitely something I'm thinking about. If it's a very large tumor, which means anything over 4 centimeters, it's just something that's in the back of my mind when I'm assessing a patient's risk. Location of the tumor matters. Does this tumor start at the top of the uterus or the fundus, or does it start at in the lower uterine segment, which is right above the cervix and vagina? That might help me think about how the tumor might spread. I look at cytology if the surgeon has taken some cells from the peritoneum or the space around the uterus. And then of course, nowadays we're looking at molecular markers. We're looking at the DNA of cancer. So one thing we look at particularly for endometrial cancer is microsatellite instability or mismatch repair deficiency. So this is a finding we see in some DNA of endometrial cancer where there's an inability to repair a certain DNA defect, and that can lead to worse prognosis, worse outcomes, but can also help tailor some of our more targeted treatments like immunotherapy and molecular inhibitors. So that can sound like a bad thing when you're first diagnosed, but can also lead to newer and more targeted treatments down the road if we need them. So just something to think about. Going back to our case, so for this patient, remember she was a 70-year-old woman. She has an endometrial adenocarcinoma. It was a grade 2, so that intermediate grade. She had 30% myometrial invasion, no LVSI, and no lymph nodes were involved. So now I can actually stage this tumor, and I'm going to stage her as a stage 1A. And why is that? That's really based on the myometrial invasion being less than 50%, and no LVSI and no lymph nodes involved. And of course, there's other things I haven't listed here, but that's what we're staging her at. This is a table for the staging. We don't need to go into details here, but I just wanted to put this here because it is very complicated. It's not just a simple, this is what you have. We look at a number of different factors when we stage patients. And this is actually no longer relevant because we have a completely new staging system that incorporates some of those molecular markers I mentioned. And that's brand new, just published a month ago. It's going to change things. We just haven't gotten to the point where it's changed treatment yet. So I didn't want to bring it in today, and it's very complicated. So this is what we still use for treatment decisions right now. And a lot goes into it, and we don't need to go into all the specifics today. So for this patient, what do I recommend? For stage 1A, grade 2, no VSI, no cervical involvement. And what do I recommend? And the big question is, why do I recommend it? For this patient, I personally would recommend vaginal brachytherapy, which I will show you some pictures of in a second. We look at risk factors. So this is a stage 1A. It's an early stage. It's the earliest stage there is. But what am I looking at for risk factors of recurrence? Age greater than 60 is actually just something to consider. Older women tend to have a worse chance of cure. So the increased risk of recurrence. So we're more aware of these risk factors in our older patients. Depth of invasion greater than 50% is one risk factor, although it's not greater than 50, less than 50. It's really a spectrum. So 49% is really no different than 51%. So I don't just look at yes or no here. It's really a spectrum. Same thing with age, actually. 60 is way different than 90. You really got to look at the spectrum here. LVSI is more yes or no, you have it, except it's not really, because the pathologist will tell you you have focal LVSI or extensive LVSI or a moderate version of it. So also a gradient. Grade 2 and 3, it seems like it's a grade 2 or it's not a grade 2. That's actually spectrum too. It's not like there's these strict guidelines. So you have to have a good pathologist, someone you can talk to and trust and understand like what they mean by a grade 2 or a grade 3, or sometimes they're like, oh, it's a grade 2 to 3, and you're like, that's not helpful. You need to call it one way or another. But it is a spectrum, so I do understand that. So for this patient, she is over 60. Her depth of invasion is less than 50%. She did not have LVSI, but she had a grade 2. And when we think about what we recommend, we want to consider vaginal brachytherapy if patient has one risk factor. Strongly suggest if 2 risk factors. And like I said, those risk factors are continuous variables. So 70-year-old is quite a bit older than 60 with a grade 2 tumor. Even without any other risk factors, I would still recommend vaginal brachytherapy for this patient. So There are studies that support this, of course, not just making this up, I swear. So what studies, what is the risk of recurrence, and what does the treatment actually look like? So that's what we'll look at now. There's 4 trials. These are randomized trials that we think about for early stage endometrial cancer. We don't need to go too much into detail here, but we have GOG99 and PORTEC-1 were the 2 original trials that we looked at. And what we were trying to look at in these early stage patients, can we omit radiation? That was the question. What we learned was that when you had some of these risk factors, there were too many recurrences. So when we looked at GOG99, the local recurrence risk, if we omitted radiation, was 9% versus 1.5% with radiation. So that's a big difference and a big benefit with radiation. PORTEC-1, the other similar trial, actually had a 15% local regional recurrence versus a 4%. Of course, it matters what year you're looking at. So GOG99 had 4-year follow-up and PORTEC-1 had 8-year follow-up. So that's probably why those numbers are a little higher. These 2 trials used external beam radiation as their radiation method. So we started asking ourselves, do we need to do external beam or can we do vaginal brachytherapy? I have some pictures that will explain what that is. And that was PORTEC-2, really looked at external beam versus vaginal brachy. We learned that vaginal brachy was preferred in this group due to side effects. The side effects with vaginal brachy were quite low. You should be here. Yes, here. So grade 1 to 2 side effects were 12% with vaginal brachy versus over a 50% with external beam. So big difference, big benefit. And then the Alders trial also showed, it's a little more complicated trial, but it basically showed that external beam definitely had some value, but not extreme value, and definitely had more side effects. So for a lot of these patients, we really just do brachytherapy alone. Here I have the National Cancer Center guidelines. I think I use this with the residents a lot just to put things in perspective. You have the stage here, stage 1A, that's tumors with less than 50% myometrial invasion, and 1B greater than 50%, and then by grade, what we'd recommend. You can see for the stage 1A, grade 1 patients, observations preferred. For the stage 1, grade 2 patient, we prefer vaginal brachy if there are any risk factors. That's what we had with this case. And then we'll go through some of the other options as we go through. I wanted to put this slide in here first I'll actually show you what vaginal brachytherapy is. This is one of my patients and her plans. Basically, I put this cylinder directly in the vagina. And I deliver the radiation through the cylinder. So you're delivering the radiation right where it needs to be. In orange here is the rectum. In yellow here is the bladder. And you can see the cylinder sits right in between in the vagina. So you can see this is a challenging area to treat. On this side view, you can see even there's bowel right up against the cylinder, and this is the sigmoid colon right up against. So I'm trying to put radiation between all these normal tissues that are literally touching my target. And the reason we love vaginal brachytherapy is I can do this and I can do it safely. You can see kind of in here, it's not the easiest thing. In yellow, this yellow line right around my cylinder, which is this white thing, is 100% of the dose. It's actually a green line. Yes, there's a green line in here, 100% of the dose. And then that dose drops down. This blue line is 50% of the dose. And it drops down within a centimeter. You're dropping down to 50% of the dose, which is what's actually touching the normal structure. So I am actually able to get good dose into here safely. These are some of the possible treatment regimens. Gray, GY here stands for gray. It's the unit of radiation we're delivering. What I recommend is 6 gray times 5 treatments delivered at the surface of the cylinder. Another option is 7 gray times 3 delivered at 5 millimeters. That is a recommended treatment option. It's a possibility. I do think there might be higher side effects with that higher dose per treatment. So I actually rarely do that. I like the 6 gray times 5. And then after external beam, there's some other recommendations, but we don't have to go into that. So that is what I have for our first case. So for early stage endometrial cancer, definitely want to consider vaginal brachytherapy if you have some risk factors. For case 2, we're going to progressively get a little more advanced in our diseases. So we still have a 70-year-old woman with pathology showing myometrial invasion of 55% in grade 3 disease. So what stage would this be? This is going to be a stage 1B because we're over that 50% myometrial invasion and grade 3 disease. And then I see a very good question here about side effects of brachytherapy. So let me just jump to that since we're talking about brachytherapy here. So brachytherapy has very few side effects for when you think about cancer treatment. It's one of the treatments that has the least side effects. I also just want to say brachytherapy, there's many different types of brachytherapy. Right now I'm talking about vaginal cylinder brachytherapy in the setting of post-hysterectomy endometrial cancer. Really mild side effects. I do this all the time, literally doing it right now. You just can't tell. You put the cylinder in, you deliver the radiation. The treatment takes about 5 minutes. You don't feel the radiation. It's like getting an X-ray or CT scan. You just have this weird cylinder in your vagina. So it's definitely weird. It's definitely uncomfortable to place the cylinder. It really shouldn't be painful to put it in because it isn't made for vaginas. The radiation has no immediate effects. You feel exactly the same when you leave as when you came in. I deliver the 5 treatments over a week and a half every other day. Over that week and a half, patients can honestly have 0 side effects, but there is the potential for some mild side effects: fatigue, loose stools, increased frequency or burning with urination. If those happen, they're very mild. I almost never have to do anything about it, like give any meds or any supportive care. What women mostly tell me is they feel like their vagina is inflamed. It's not like they're calling me, telling me that. It's just, they're seeing me 2 days later when I do the next insertion and procedure. And I'm like, how you doing? And they tell me, I just feel like it's a little inflamed. And it's not really a complaint. My patients do very well with this treatment. I think more the downside than physical side effects is the mental, like this is a mentally challenging treatment. For many women, it feels very, just a lot of trauma with this. Most women have had bad vaginal exams in the past, some bad experience with some pelvic exam or procedure that was challenging, painful, under-medicated. There might be some trauma history that they're dealing with. So I think emotionally this can be a very challenging treatment to undergo. You feel very exposed, even with my team when we try as hard as we can to make it as comfortable as possible. But I do have patients who struggle with this. That being said, I think if you just talk it out, explain everything you're going to do, have the same team be supportive, be there, it's very reasonable to undergo. Long-term side effects are much more important to me because these are early stage tumors. I'm planning to cure them and have women have their normal life expectancy with this treatment. I don't want to impact their life with side effects. So what are the chances of long-term damage to the bowel, the sigmoid colon, the rectum here, the bladder here? All these structures are right next to the treatment site. So what are those long-term risks? Less than 1 to 2% of any long-term side effects with this treatment to those organs. It's not 0, but it is low. Most of my patients in follow-up who just undergo vaginal brachy, we have like social visits for follow-up. There's really not a lot of side effect management long-term. And I follow my patients for 5 years at minimum. The one side effect that will happen, we can prevent, and that is vaginal stenosis or scar tissue of the vagina. And this is something I'm actually very passionate about preventing, and it is 100% preventable. So there's really no excuse for this. Basically, the vagina is always closed unless we put something in it. After getting cancer, surgery, radiation, body gets confused and wants to heal it. So it starts to form scar tissue at the top. Simply by putting something in the vagina, we can prevent that scar tissue from forming. But it's something we have to do repetitively. And, you know, sexual intercourse counts, but it doesn't happen consistently for most people. So we do something called vaginal dilators, and I can talk more about that and give some maybe some information that I use we could give out to the group if people are interested. I have another question about case 1 here. We can talk about side effects of external beam a little bit later when I have an external beam case. And then you can definitely skip the transvaginal ultrasound in postmenopausal women. That is true because it, like I said, even if it doesn't show anything, you're going to end up doing the biopsy. So I'd leave that up to the GYN oncologist. You can still get more information from the ultrasound though. So it's not really a bad thing to do. Regardless, I personally would want to get that ultrasound, but it's not necessary. Okay, I think that takes us through case 1, unless there are any last minute questions on case 1. And I can talk more about dilators at the end if we have time. I have a whole special talk on dilators. That takes me a long time though. So, okay, jumping into case 2, where we'll talk about the external beam side effects. So like I said, this was a stage 1B grade 3 disease. What is our recommendation and from what study? We could talk about the Alders trial, which included 1B grade 3 disease. We saw a local recurrence free benefit. Local recurrence decreased from 25% to 5% with external beam radiation. So we definitely want to consider external beam radiation for these patients. Since it's 1B grade 3, this is kind of a group where you can do a number of different things. I would do 45 gray of external beam plus vaginal cylinder brachytherapy, although there's not strong data to add the vaginal cylinder brachytherapy, but we know with grade 3 patients, they are at a higher risk of recurrence. So it is recommended to consider it. However, my GYN oncology colleagues have now started recommending chemotherapy for this population. So when they give chemotherapy, I might want to de-escalate some of my radiation. So this one is less clear. And there are a lot of different options. You could do chemo and vaginal cylinder. You could do chemo and external beam. You could do external beam alone. You could do external beam and brachytherapy. And all those options are actually probably pretty good with recurrence rates about 5%. So they all work. We just don't have a lot of randomized data pushing us one way or another with this group. These patients were included in a study called PORTEC-3, which we will talk about later. But this subset of group patients didn't benefit from the addition of chemo to radiation. So there is this debate on these patients. And I think I'll probably leave it at that because it gets a little complicated. So a review of some stage 1 recommendations. So for stage 1A, grade 1 or grade 2, you can consider observation or vaginal brachytherapy if there are risk factors. For 1A, grade 3 patients, I prefer vaginal brachytherapy. For 1B, grade 1 or grade 2, also vaginal brachy. It's the 1B, grade 3 patients that it's a little complicated. You could do external beam, plus or minus vaginal brachy, plus or minus systemic therapy. I think external beam is still standard of care, but I always discuss this with my GYN oncology colleagues to come up with a consensus. Was that a question? And then I always add vaginal brachytherapy to external beam if the cervix was involved by tumor, because that cervix sits right at the top of the vagina and increases the risk for vaginal recurrence if that's involved. I think that's the group that we have a little less randomized data for, but all the options are actually good. You just need to talk through the options with your patient and your colleagues. So this one's a little more clear. We have a 70-year-old with endometrioid adenocarcinoma, a grade 3 again, 65% myometrial involvement with cervical stromal invasion. So the cervix is involved by tumor, no lymph nodes. That makes this a stage 2. And what's the treatment for a stage 2? You can do external beam and vaginal brachytherapy. Like I said, I would do 45 gray of external beam followed by vaginal brachytherapy. You could also argue to add chemotherapy to these patients, just like with those stage 1B grade 3s. So this is what I want to talk a little bit more about the external beam radiation. We'll talk about side effects as well. Do I ever offer external beam radiation targeted to vaginal cuff instead of brachytherapy? That is a good question, but no is definitely the 100% no. External beam can never be as targeted as brachytherapy, whatever many of my radiation oncology colleagues may tell you. They just simply don't do brachytherapy. Really, brachytherapy is the most targeted type of radiation that will ever exist. This is the old staging system, not the new staging system from a few months ago, because that's very new and we're not using it for treatment yet. We need a little more data for the new staging system. So this is the 2018 staging system. Okay. Thanks for all the questions. So for external beam radiation post-hysterectomy, you must always do something called IMRT, or intensity modulated radiation therapy. This is as opposed to an older technique called 3D conformal radiation, or a 4-field box technique. Didn't actually include pictures of that, but here, this is a picture of one of my patients that I did IMRT for post-operatively. And what you see in purple here is what I want to treat. These are the lymph node regions in the pelvis. You can see they run right in front of your lumbar and sacral spine. And then this is the vaginal cuff here in purple. This is another way to look at it, all the 3 different views we use. And then the other colors are the dose. So in red, you see the prescription dose of 45 gray, and then the dose slowly falls off to, this is the 50% line. And what you see is I've looped or pushed the dose outside of all this bowel in the middle. Is some bowel getting radiation? Yes. And that's because despite this being a highly modernized targeted technique, it is external beam and you will get radiation to that bowel. And then lower down, you would see it. I've spared much of the rectum here. And then this is the bladder here, also getting largely spared by radiation. So I'm trying to spare all this bowel, this bladder, and then the rectum posteriorly. For the technique, I think this is a little too detailed, but briefly, for external beam radiation, you start with a CT simulation. That's a planning scan where we make a beanbag mold for the patient to lie in to keep the hips and the legs in the same position every day. I put markers in the vaginal cuff. They're gold or platinum. They stay in forever. And I can see them every day on my planning machine so I can target to that area better. I fill the bladder with urine. Well, no, I don't do it. I have my patient drink water to fill her bladder with urine. And I do a scan with a full bladder. Then I have her pee and I do an empty bladder because the organs move as the bladder fills and empties, and I want to account for that. I also use IV contrast to see the lymph nodes better. And then I'm covering a bunch of different lymph nodes. We don't need to go into that too much. So I have a message here. Yes, we will talk about SBRT and or brachytherapy for recurrences in lymph nodes or other areas. This is more what I'm talking about with IMRT, is where you want to treat the whole pelvis, all the lymph nodes that might be involved. So that includes the common iliac nodes, the presacral nodes, the external iliac, internal iliac, and the obturator lymph nodes. So I actually want to treat a bigger area. I don't want to be too targeted because then I'm going to miss areas where there might be lymph node disease that I can't see. So that's why we're treating not with an SBRT technique, but we will talk about that. So when do we add chemotherapy for stage 1 and 2 disease, and what are the studies? So we're going to look at a few studies here, not go into too many details, but this was a randomized study, GOG 249, and it compared external beam radiation versus vaginal brachytherapy plus 3 cycles of carbotaxol. And what we learned was that external beam for these patients was actually better than vaginal brachy and 3 cycles of chemotherapy. In terms of overall survival and recurrence-free survival, things were equivalent, but there was more toxicity with the chemotherapy arm. So for stage 1, stage 2 patients, we still prefer external beam alone. The study was criticized, however, because many of us thought that there wasn't enough chemo, that perhaps if we had done vaginal brachy plus 6 cycles of chemo, that would have had greater benefit. We still haven't run that trial yet, so we are not sure if that is the case. Instead, we ran this trial, which is PORTEC-3. It's a very exciting trial that came out while I was a resident. This was looking at higher risk endometrial cancers. It included those 1B grade 3 patients, stage 2 or 3, and it also included high-risk histologies such as clear cell and serous carcinomas. And we compared external beam, that was the standard care for these patients at that time, and we compared that to external beam with radiation sensitizing chemotherapy or cisplatin, followed by 4 cycles of carbotaxol. Overall survival and freedom-free survival were equal for all comers, but we saw an improvement in survival and survival without recurrence in stage 3 patients. So what we learned from this study was for those stage 2 patients or those stage 1B grade 3, external beam was still standard, but for stage 3 patients, those are patients with lymph node metastases, we do prefer a combination of chemo and radiation. Okay, so now we'll look at some of these lymph node positive patients and what to do. So we have a 70-year-old patient here who had 50% myometrial invasion, the cervix was involved, and 1 out of 10 pelvic lymph nodes was positive. This would make this a 3C1 stage. And if a periortic lymph node is positive, that would make it a 3C2, but we're going to treat this 3C1 patient. And you have a lot of options on how to treat this patient. Fortunately, this isn't like a simple recipe book where you put your ingredients in and get something out. There's a lot of different options. You have to think about a lot of different things. You are going to do some form of combination of chemotherapy and radiation for these patients, probably. Many different options. You can consider the PORTEC-3 regimen that we mentioned here, the external beam, the chemo radiation, and the carbotaxol ×4. That's randomized data that showed there was a benefit for stage 3 patients. So that is a good choice, but it is not our only choice. You can do a regimen called the sandwich regimen, which isn't done too much anymore, but was done while I was in training a lot. And that was doing 3 cycles of carbotaxol, then fitting external beam radiation in the middle, and then doing 3 more cycles of carbotaxol. More common is doing 6 cycles of carbotaxol followed by external beam radiation. But in a recent trial, GOG 258, we actually compared 6 cycles of carbotaxol alone to the PORTEC-3 regimen, and we saw little benefit with the addition of radiation. So in some cases, you can actually just do chemotherapy, 6 cycles of carbotaxol alone, and omit the radiation. How do we decide? It's luckily, at least at UCLA, it's not just what we feel like doing or what we prefer. We actually have a consensus, we make a consensus opinion among many physicians, and we think about where is the patient most at risk of recurring. If there's a lot of risk factors for local recurrence or regional recurrence in those pelvic lymph nodes, then I am going to want to do radiation, and I'm going to want to do radiation soon, and I might want to do a PROTECT-3 regimen. But if the risk is greater for distant metastasis, like with a high-grade serous carcinoma, where we're more worried that patient's going to have disease outside the pelvis, then we're going to want to start with carbotaxol, 6 cycles of carbotaxol. And then the radiation becomes less important there. Does it mean it's not important? No, but we want to start with what's most important. So that's how we're thinking about it. Where is the risk of recurrence? Where is it greatest? What do we need to get in? And also, what can the patient tolerate? We really need to think about the whole picture. Can the patient tolerate 6 cycles of carbotaxol? Sometimes I get patients who really have a history of like severe neuropathy, and one of the side effects of Taxol is severe neuropathy, and they really can't tolerate it. So then we might want to focus more on radiation. Other patients maybe have irritable bowel disease and can't really tolerate radiation in the pelvis. Of course, we might want to prefer chemotherapy. So we're really looking at the whole picture. So from Jacqueline, which is mentioning very correctly that molecular sequencing is needed. We do molecular sequencing for all endometrial cancers routinely now. And the new staging system has incorporated these molecular sequencing. What we don't have yet is data on how the molecular sequencing is really impacting survival in a randomized setting. We have where we've gone back and looked at patients who had, let's say, MSI high. We kind of see which treatments may have worked better or less good for those patients, but we don't have randomized data yet. But that study is coming. That's PROTECT-4. I love PROTECT trials. PROTECT-4 is going to give us so much data, randomized data about how molecular sequencing affects patients and treatments. So we will have this data upcoming, in the next 5-10 years. We just don't have it yet. So we have to be careful about using molecular information to choose our treatments, because we really don't have randomized data. That doesn't mean we don't have any data. That doesn't mean we can never use it. We can always think about it. We do think about it. We do get the data, but we need to be careful. Cisplatin is used to boost the radiation, or the way I think about it is it's a radiation sensitizer. So it sensitizes cancer cells to radiation, making my radiation more effective. It's used in many different cancers, but particularly head and neck and GYN cancers with radiation. Oh, just another question there. So moving on to case 5. We have a 67-year-old with a 3-centimeter vaginal recurrence, status post surgery for early stage endometrial cancer 10 years ago. So basically, this patient probably had an early stage endometrial cancer, got a hysterectomy, didn't require adjuvant treatment, but now has a recurrence in the vagina. What's the workup here? I think the most important thing is to restage with a PET CT. We want to make sure there's no disease anywhere else, and is this an isolated recurrence? I also will always get a pelvic MRI. The uterus is gone now, and now there's just a vaginal cuff. The bowel falls down into the pelvis. The rectum's right behind the vagina. The bladder's right in front. I need to know how this tumor is interplaying with those other organs. Is it invading into the bladder, rectum, or bowel, or is it free from those organs? So the pelvic MRI is often the best way to look at that. I'm of course going to get a biopsy. I need to prove that this is a cancer recurrence. We also want to get those molecular markers on this to see if there's any targeted therapies we can use. And then I'm asking myself, has the patient had prior radiation or not? Because that's going to help impact what I can do with radiation. So this patient had not had prior radiation. We did a biopsy, and it was consistent with a recurrent endometrial cancer, and the imaging showed there was no regional or distant mets. So this is an isolated local recurrence of endometrial cancer. What's the treatment for that? That treatment is combination of external beam radiation, brachytherapy, and I recommend concurrent cisplatin for these patients, even though there's little randomized data to support that. But from our clinical experience, we know that radiation will be more effective if we add that cisplatin in. So the external beam radiation is very similar to previously. It's 45 gray to the whole pelvis. I want to cover any lymph node regions, but I of course also want to cover the vagina, the vaginal cuff, and the recurrence. The brachytherapy here is what is potentially very different than the vaginal brachytherapy I talked before. If the tumor is greater than 5 millimeters thick in that vagina, I can't treat it with a cylinder. So what's very important is to do an exam, to get an MRI, assess that thickness after the external beam radiation is over. If it's 5 millimeters or greater, I need to do what we call an interstitial brachytherapy implant. I can't treat from within the vagina itself. I actually have to put some needles directly into the tumor to cover that thickness better and safer. And I do have a picture of that here. So this was one of my patients years ago, and she had this very thick vaginal cuff recurrence, and it curved out to the left pelvic sidewall, actually obstructed her ureter and caused hydronephrosis. And these black little holes here, these are the tubes I put directly into the tumor. And I delivered the radiation through it. So you can see this is the 100% and the yellow is the 90% dose. It's not even touching the bladder and the rectum here, and the bowels here, and the sigmoids here, and everything's right around, but I can get all that dose in safely. If I had just used this cylinder to treat it, you could see I would, well, I don't know, I would just be able to treat like right here, and I wouldn't be able to cover the thickness of this tumor at all. Would that be an inpatient procedure? So there's many different ways to do interstitial brachytherapy at UCLA. We often do it as an outpatient because we just have a lot of resources and can do it quickly and efficiently. So I would do multiple procedures, typically 3 procedures once or twice a week as an outpatient. Takes about 3 or 4 hours total. But I also have patients who come from far, and at most other institutions who don't have our resources, it is often done as an inpatient, and patients stay in the hospital. Yeah, and my patients who come from over like 3 hours away, I'm not going to make them drive in LA 3 times. It's a nightmare. So I keep them in the hospital and get all the treatment done. And what are our cure rates with sorry, there yet? Yes. Okay. Cure rates are pretty good. This is one of the few recurrent cancers where we have a good chance of cure. Our local control is 60 to 90%. I'd say it's closer to that 90% when I put those interstitial needles in. Really gives me good coverage. Overall survival, unfortunately, is a little bit lower because often we think that recurrence is isolated. We can't see it on the PET scan. We can't see it anywhere else, but there might be microscopic cells elsewhere in the body. This is where those molecular markers really come into play. So we can think about combining the radiation with treatments such as pembrolizumab or immunotherapy to really help with that systemic control of disease. In this setting, the patient hadn't had prior radiation, so I did external beam and vaginal brachytherapy patients. And all of you often ask, what if the patient had radiation before? Can we do brachytherapy again? Yes, we can. So if a patient has already had external beam or even vaginal brachytherapy during their initial treatment stage, and then they recur afterwards, can I do radiation again? I can, but I would only do that interstitial brachytherapy like this because I really am able to get good dose into this area while sparing those normal structures. So we typically will do 6 to 8 treatments of brachytherapy in this instance. And then of course, I would definitely keep the patient overnight to get those multiple nights to get all that radiation in. And then I know we're running out of time. This is actually my last slide, so I did good. This is a patient who had a hysterectomy and then had a vaginal cuff recurrence. And despite being in Los Angeles and having access to good care, the tumor was allowed to regrow, and she came to me with this tumor. This isn't a uterus. This is actually all tumor that grew back. And it was involving the sigmoid colon right here. So I recommended a colostomy to move the colon out of the way, and that allowed me to deliver curative radiation dose despite the patient having prior radiation, and I was able to control all this tumor, and she has no evidence of disease about a year after. I think she's over a year out from this. And when she came to me, she couldn't even sit up because she was in so much pain from this tumor. And since treatment, she's able to enjoy her life in a very meaningful, wonderful way. So I think brachytherapy can be an option when other physicians tell you there are no options. Sometimes we can do these very large implants. I probably put almost 15 or 20 catheters into this tumor, delivered the radiation, and she'd be great. So now that I have a minute left, I'm going to open it up to more questions, although I think I answered many questions during the talk. I can open it up if people want to unmute themselves and ask questions out loud or keep typing, or I can also answer the questions that were sent to me as well.
Okay.
What do we prefer?
I think maybe you answered the questions that we sent, and maybe people can add to the chat. So while you're
Perfect.
answering questions, they can type.
So the first question is it important to get a bone density scan after treatment? I think all women over the age of 50 should be getting bone density scans every 2 years, I believe is the recommendation, although don't quote me on it, talk to your primary care doctor. I recommend all of my patients get a bone density scan after treatment. When we do external beam radiation, that's not external beam. Come on. Okay, when we do external beam radiation, all this bone does get some dose of radiation. Even though I am pushing the dose off of that, the lymph nodes live right in front of your spine, and it's going to get dose. Also, the femoral heads here, you see I pushed the dose off of them, but they're still getting some radiation. We do weaken those bones. So women are at risk of sacral insufficiency fractures. That's where the sacrum just fractures on its own without really any inciting event. And it can be extremely painful. So yes, bone density is important. And I also strongly recommend all women, including myself, hypocrite here, take vitamin D and calcium every day. You take them together, you absorb them better. Bone strength is important, and weight-bearing exercises. We should all be doing them. Let's improve our bone health. Diet for radiation. I don't have a specific diet for radiation because every patient's digestive system is very different. I kind of take it one day at a time. We see our patients once a week at minimum during external beam radiation. Plus you're here every day, we're here every day. So there's a lot of communication. So I kind of say, I talk to my patient before, if their bowels are working okay, I say, let's continue what you're doing. And then as effects start, we adjust the diet accordingly. Most side effects from external beam don't start till week 3 or week 4 of radiation. So we have time to kind of address things as they come. In general, the thought is to decrease the fruits and the vegetables that might cause gassiness or cause diarrhea. The thing is, not everyone is the same, and those foods are good. So I tell my patients, just eat a healthy diet. Don't try to lose weight. That's not what I want you to do. Protein's really encouraged. Staying hydrated is encouraged. Just being healthy is good, but don't go crazy. This isn't the time to start a new diet and make your digestive system goes crazy. Let's just take it one step at a time. What can we do to minimize side effects short-term or long-term? I think number one thing you can do is, if it's at all possible, go to an academic center for your radiation. GYN cancers are not well taught in residency. Some residency programs don't see a lot of GYN cancers. It's not something that our country prioritizes. Unfortunately, I fight for time with my residents, and I'm at an academic institution. I think Also, they're not the most common cancers that are radiated. So I do think coming to someone like me or another academic institution is preferred. Someone who treats a lot of external beam GYN for brachytherapy, 100%. Please come. Go to an academic center if at all possible. And I know not everyone can travel, but these are short treatments and it is your life, and these side effects will last forever. Once radiation's given, it can't be taken back. Brachytherapy is very specialized. These are high doses of radiation given in a surgical manner and should not be taken lightly. Dose for vitamin D, please talk to your primary care doc on that. Everyone's a little different there, and I'm not up to date on those recommendations. Oh, I didn't get to talk about meds, did I? I want to talk about meds. And okay, great question. So let's talk about meds. I thought I had slides in here. I must have taken them up because I knew it was getting too long. So I'm not just going to talk about liver mets. Let's talk about mets in general. If someone has less than five or less metastatic sites, whether it's lymph nodes or in the lung or in the liver, we consider that oligometastatic disease. We think that is a different entity than if you have like diffuse mets all over the body. Anything greater than 5 is considered diffuse. And we have this belief that we can still offer long-term control for patients with 5 or fewer mets if we give local treatments to those lesions. And those local treatments are typically given in 2 ways, but I'll talk about 3. The most common is stereotactic body radiotherapy. That is what one of our members got for a lymph node recurrence. And I do this all the time, and it's usually delivered in 5 treatments. Every other day or every day can be fine, and it's targeted radiation just to that site of disease, wherever it is, and it can be done anywhere in the body. Another option is to actually do brachytherapy to those mets. You can put a needle, just like when you get a biopsy, the interventional radiologist puts a needle in to take tumor out. You can put a needle in to put radiation in, and I can treat a metastasis from inside out. I can get higher doses and less radiation to surrounding structures than even with SBRT. Downside, of course, it's a surgical procedure. You have to put that needle in. You often have to do it maybe 3 times. And there's sometimes it's not possible to get a needle in. Sometimes there's no benefit to brachy versus SBRT. I like to do both. I do both, so I'm always thinking about both options. Dilators. Okay, let's get to dilators. Ooh, gut questions. I love it. So for dilators, this is individual. You should use your dilator till Dr. Venkat tells you to stop. That's what I tell my patients. Basically, depending on what radiation you get and your own body, some women do not get scar tissue, and I can wean them off very quickly in 3 to 6 months post-treatment, and they're sexually active and everything seems normal. They really don't need it. Other women get scar tissue, and we have to continue it for life. That is that possibility. So at every follow-up, I talk to my patient. How are the dilators going? Are you doing them? How's sexual activity? Is it painful? Is there bleeding? I do the exam. I look for scar tissue. If there's no scar tissue, if everything's good, I decrease the frequency. Maybe they were doing it every other day. I decrease it to 2 times a week. But then let's say we decrease it and side effects get worse. Maybe sexual intercourse becomes painful. We go back to the more common ones. So I have my own protocol. I'm happy to share with the group my protocol. My protocol comes from my patients, from talking to my patients and just working with them and learning about how vaginas react to this treatment. There's not a lot of data out there. I'm working on a paper that talks about the limited data there is out there, and then ends with my protocol. And I'm also doing a study looking at the vaginal microbiome pre and post radiation and correlating that to side effects. So there will be data. It's just this isn't something the medical community cared about for generations, but that is changing. I am here and I'm doing some of this work. Microbiome So that is a very good question. I'll read the question just so everyone has it. It's basically asking, does the microbiome gut health can impact the effectiveness of immunotherapy? And given that the radiation impacts the gut, will radiation impact the effectiveness of immunotherapy? That's a very good question, very reasonable. In general, we find that radiation makes immunotherapy more effective, however, is what we've seen in most studies, often in the brain with melanoma, but also within the pelvis. I often combine more targeted types of treatments like SBRT or brachytherapy with immunotherapy, because we think that as we kill the cancer cells, that's going to release cancer proteins into the bloodstream, allowing the immune system and that immunotherapy to find these cancer proteins and then attack it elsewhere. There's many studies that have shown this synergy. I do think it's a very good question if you're doing less targeted radiation, like when I'm treating the full pelvis. For a cervical cancer trial that was just published, we combined external beam with chemotherapy with immunotherapy. And there was a small benefit in disease-free survival, but not as big of a benefit as we expected. And perhaps that is because we messed up the gut microbiome. I don't think that's an unreasonable supposition. I think we still need to do more research on that. But I think combining immunotherapy with the more targeted types of radiation is really the way to go. And we're really seeing, we did a trial with brachytherapy and immunotherapy. There's studies coming out. We're getting more and more data every day. Okay, so if you decide not to do adjuvant radiation, what you should do in follow-up is, and this is actually probably true whether you do it or not, vaginal exams are the most important follow-up for endometrial cancer. And that is because people are like, why don't I get a PET scan or MRI or CT chest? Most early stage endometrial cancer recurrences, greater than 75%, occur in the vagina. And we can see and feel a vaginal recurrence long before it'll show up on an imaging study. So those exams are critical. The recommendations for follow-up exams are every 3 to 6 months post-treatment. I strongly encourage you to do them every 3 months for the first 2 years. That's what I do for all my patients. 3 to 6 months, that's a big difference. So I don't really appreciate that recommendation by the National Cancer Center guidelines. Just do it every 3 months for 2 years. Then I start spreading it out to 4 months for year 3, and then I do every 6 months for year 4 and 5, and then I do annually. That's if everything is normal, you have no side effects. If someone has vaginal bleeding or pain with intercourse or any bowel or bladder changes, that should trigger an earlier pelvic exam. I do think those exams are much more important than the imaging studies. Okay, so this is a tough one. So it sounds like there was a recurrence on the labia and the vagina, and we underwent external beam radiation. Anytime you treat the vulva, so the labia or the external area, or skin in general, there is going to be that burn reaction. Skin epithelium is a fast responding tumor. So when you radiate it, it basically scrapes off the surface of the skin over and over again, and it regrows and scrapes off, regrows. So that's very common when I treat vulvar cancer, to have those reactions. One way to minimize those reactions is to do a little less external beam and do a little bit of brachy, because the brachy is just treating less skin, so there's less of that burn. That being said, that should only be done by people like me who do brachytherapy for vulvar cancer. It's very specialized, and there's actually not a lot of data to support doing brachytherapy for vulvar cancer. So this does sound like it was probably standard treatment. It's just really, really hard treatment. Sometimes, like vulvar cancer is my least favorite thing to treat because it does cause so much pain and this burning reaction to patients. I really, really hate it. I love this question, MRI guided radiation. So MRI guided radiation is great, but it's only helpful if an MRI is going to help you see your target better. That's actually not always the case. We have an MRI guided machine here. I'm always thinking about whether I can use it or not. There's some downsides of it. Yes, the imaging's better, but the treatment is actually a little limited because of that MRI and the electron linear accelerator. We're not able to do some of the cool manipulation of our photon beams with our MRI machine that we can do with a CT guided machine. So I really think you should use the MRI machine only when it's needed. When is that? Typically with pelvic diseases, if you're targeting in like a small lymph node that's near bowel, you can probably see the lymph node on your CT guided machines and your MRI guided machines, but what you can see better on the MRI machine is the bowel. So you can actually adapt your treatment daily to get it off the bowel as that bowel moves. So that's something I like to do a lot here. Where else is liver help? MRI is really helpful for liver mets. That is way better than CT. And then for any sort of pancreas tumor, not really relevant to this group, hopefully, but that's where it's extremely beneficial. So yes, it's cool and it's sometimes better, but not always. So yes, Barbara, yes, you always continue with vaginal exams. Basically, you always continue with vaginal exams ever. If you ever get radiation to the pelvis, you should be getting vaginal exams. Highly important, not only to look for tumor, but also to, in this setting, you got external beam and brachy. We need to look for scar tissue, for ulcerations, radiation effects. So yes, please. I really am a believer in that you can't do too many vaginal exams. It's not really true. You can, but nobody does. I don't like all these guidelines, particularly for pap smears, moving it to every 5 years. I really think we should be doing more vaginal exams for women because we can prevent cancer deaths. Strongly biased opinion though. Okay, I have more questions on the page, so I'm just going to keep reading.
Okay. Go for it.
Is one type of radiation more tolerable for most? Hard question to answer. So many different types of radiation. Let's talk about external beam versus brachytherapy. Definitely brachytherapy is typically more tolerated because you're just treating a smaller volume. It's more targeted, less dose to normal structures. So yes, typically much better tolerated. Of course, it's more of a procedure. In a very sensitive area, the vagina is not an easy place to get treatment. So mentally, emotionally, it can be tougher to get brachytherapy. And then there's other special types of brachytherapy that maybe cause more pain or discomfort or more of an invasive procedure. So it somewhat depends on the situation. So when you think about reirradiation, yes, it can be done. What matters is time in between radiation. Normal tissues do heal over time. So the longer you are from the previous radiation, the better. Also, in general, brachytherapy is the preferred type of reirradiation because it's going to be more targeted, stay off those normal tissues as much as possible. So there's not really a limit to how much radiation a person can get, but there's a limit to how much radiation a structure can get. So bowel, one specific loop of bowel can only get so much radiation. That doesn't mean all the bowel can't get that. So it's really anatomically driven and time driven. But yes, I do generally recommend brachytherapy for reirradiation. And also definitely something that should be discussed at an academic center if possible. And can you have additional brachytherapy? Yes, I think we've discussed that. Recent developments in radiation technology. So brachytherapy is not new. I still think it's the most technologically developed and advanced, and we do change our techniques on the daily. It is patient specific. We're never doing the same. Every procedure is specific to the anatomy of that time and that moment. We do live imaging, so it's going to be hard to be more advanced than brachytherapy, but we have the cool MRI guidance for imaging. We are doing adaptive external beam radiation, where we can adapt the plan on the date of treatment based on where the anatomy is in that moment. What else do we have? Proton therapy. I didn't even talk about protons. Protons are cool, and I generally get asked about. So most of the external beam radiation I talked about is photon treatments. Photons are, think of them as packets of light or energy. They go in, they go out. They're like X-rays. Protons are heavy, and they can, because they're heavy and they have weight, they can be stopped within a patient. So we think we can stop them. We have a field that say you have a tumor and then you have the spinal cord, and we can stop the dose right in front of the spinal cord. It sounds great in theory, and it is very good for children because it decreases the total radiation dose in the body, the integral radiation dose. And it could be something that becomes more generally utilized in the future. The problem with protons is they're so heavy, they're hard to manipulate. So in theory, we're like, yes, we can stop our dose, but it's hard to get the protons where we want them to go to stop them. They're very hard to manipulate. All the new fancy technologies where we can block things and treat from 360 degrees, it's really hard to do with protons. So definitely some downsides. Strongly don't recommend protons for most adults unless you're talking about brain or spinal cord. There's really minimal benefit, and there may be some downsides. We also don't understand how they really work in the body that well. So we're still learning, and we understand how photons deposit their dose in the body. The protons, not as well defined. Also, as air, protons, when they go through air versus soft tissue, the dose is going to change a lot. So as bowel moves around, that dose you think you're delivering is probably not what you're delivering, and it makes me a little nervous in the pelvis. So I don't think we're quite there yet in general. Okay. I think that's it for developments in radiation oncology for now. That'll be enough. Hospital stay for brachy, only if needed. Like I said, we do a lot of outpatient brachy. The vaginal cylinder brachy is definitely outpatient. Takes about 20 minutes total. You're in and out of the department real quick. For us, for interstitial brachy, where I'm putting those tubes in, often we do it as outpatient, but we also do it as inpatient, whatever works for the patient and the situation. So the burns from external beam in the pelvis area, that really shouldn't happen if we're treating just endometrial cancer, because that all of this is inside the body. There's actually a skin sparing effect when we use photon radiation. But when you're treating the vulva and the labia and the skin, that's when you get those burns. Or if you're treating the groins, if you have a vulvar cancer and I have to treat the inguinofemoral lymph nodes in the groins, that's very close to the skin surface, that's where you get those burns. Or if the distal vagina is involved with either a cervical or endometrial or vaginal cancer, I have to treat those groins, that's when you get those burns. Otherwise, you really shouldn't get them in this country with our technology. With some of the older technologies, like cobalt-60 machine, but that really shouldn't exist anymore in this country, and I don't think it does anymore. Not 100% basically. So hopefully that's not a thing. Okay, I'm still going. That's a little too treating lung and liver mets. I think we talked about. There was a specific question about hemorrhoids. What I will say about hemorrhoids is external beam radiation aggravates hemorrhoids. And some people find out they have hemorrhoids for the first time during radiation. What can you do about that? You really can't change the radiation to avoid that area. We're always pushing off the rectum as much as possible anyways. So we really have to manage them medically. So warm baths, sitz baths, hemorrhoid creams. I like the hemorrhoid wipes, the preparation H wipes, just being really gentle with that area. Talk to your provider. Definitely don't want to skip radiation because of hemorrhoids, so we should be managing those medically. I love Tomo. Tomotherapy is a machine. So we have a machine here. It's a type of linear accelerator that uses CT guidance, so very typical, but it delivers the radiation in a helical or a CT form. So basically you have a donut like you do for a CT scanner, and the patient moves through the Tomo machine rather than the machine moving around the patient. And it does deliver really great plans sometimes for pelvis, lymph nodes. I do love my Tomo, but it's just kind of like another brand name. It has some benefits, definitely has some downsides. A lot of people find the Tomo unit quite hard to use. I personally love it. We are replacing our Tomo with a newer machine called the Ethos, and my heart is breaking inside. But all machines have pluses and minuses. It's a good machine though for IMRT or pelvic radiation. Okay, so Julie, I understand your question to mean, what do you need other than vaginal exams for an early stage cancer that didn't get adjuvant treatment? So the recommended follow-up is just vaginal exams every 3 months for 2 years, and then extended out to 5 years, and then annually. Imaging is not recommended because the data has shown that it really doesn't show us recurrences before those vaginal exams. So it won't be covered by insurance and really is not recommended to be ordered or done. So those are just the recommendations by the National Cancer Center guidelines. And I know that can be frustrating. You're like, why can't I get a PET scan? Why can't I look at the whole body? Really the reasons are many: financial, medical. The way I think about it is, if we do a PET scan on everybody, we will find questionable findings. Everyone has questionable findings on a PET scan. We rarely do a PET scan and say, oh, there's nothing. There's always this, but this brightness here that might be something but isn't, and it leads to unnecessary concern, anxiety, biopsies, that biopsies do have risks with them. I've had many patients who've had a lung biopsy because they got a PET scan which showed something, and then they have a pneumothorax and they end up in the hospital with a chest tube. There are real risks to all these procedures, and we shouldn't be doing imaging unless it's indicated, unless you have a side effect. If you have vaginal bleeding, we do an exam. If the exam's normal, I would get an MRI at that point, but there should be something you're looking for, because these cancers do bleed when they recur, and they do cause, we should see them and feel them before. I often can see and feel a recurrence that's biopsy proven that I can't see on a PET scan, I can't see on an MRI, definitely can't see on a CT scan. So our eyes and our fingers are better than imaging. Imaging is just like, it's not a picture. It's much inferior than a picture or a camera, because it's us using technology to reproduce the inside of the body. And the imaging, yes, it's amazing and the technology's improved, but it is still less good than my eyes and my fingers. So those exams are better. Continuing.
Yeah, let's do just a little more, maybe a couple more questions.
Okay. So lymphedema came up a few times. So radiation-induced lymphedema in the pelvis is pretty rare unless you're treating vulvar cancer, because you're typically not treating those groins, which is what causes it. It's rare, but not never. Compression stockings are good, but there's also usually lymphedema clinics you can go to, which is a mix of physical therapy and massage therapists, and that can really, really help. So I definitely think you should either ask to go to a lymphedema clinic or get some specialized care for that if it happens. You have burning during urination. Yes, that doesn't go away. The burning after urination should go away if it's caused by radiation. That's not typically a long-term side effect. It can happen with dryness due to lack of estrogen. That I've seen linger longer, and also if someone's having recurrent UTIs, which can also be increased because of that lack of estrogen and dryness. So I do think if you're having burning that is still there 3 months after radiation when you urinate, that does warrant more workup. I would recommend a urology consult, probably do a cystoscopy to look in there and see what's going on. Yeah, because that's not typical. When you start getting checked. So, yes. When do you start getting checked? So the way I think about it is after your last treatment, whether it's, usually get surgery, then chemo, then radiation, or surgery, then chemo, or just surgery, whatever the last treatment is, you should get an exam 3 months after that. At minimum, some surgeons, the gynecs, will do the first exam 3 months after the surgery, regardless of what subsequent treatments you're getting. That's also okay. But you typically can wait till that adjuvant treatment, that happens right after surgery, is complete to start those 3-month exams. I did want to mention something about serous carcinomas, because there was a question about it, and high-grade serous carcinomas are more aggressive type of uterine cancer. They are often at risk of distant metastasis, and we also think of them as more aggressive. So people often think maybe they don't respond to radiation. Well, they actually do. They respond very well to radiation in the local region. Wherever I'm radiating, they respond well. The concern is that they may recur outside my radiation field. Wherever I end that field, the risk is they will recur outside. So that's why we do like to do chemotherapy for those patients as the primary treatment, and radiation tends to be either added after or concurrently, but I often want chemotherapy first for high-grade serous cancers. Okay, I did want to talk about side effects of radiation in general. You have to think of short-term side effects and long-term side effects. Short-term side effects are side effects that occur during radiation or up to 3 months after, and those are generally transient. Those aren't what we're worried about long-term. For pelvic radiation or brachytherapy, we're worried about the things in the pelvis, bladder, bowel, mostly. So increased frequency of urination, burning with urination, loose stools, diarrhea, urgency to go to the bathroom. That's a big one that I don't think I mentioned earlier. It's like urgency, but we do not cause frank incontinence. We're not cutting the nerves. We're not damaging the nerves. But we're just kind of slowing down the function of those nerves. So there's a lot of urgency to go. That should get better with time, but may not go away completely. So what are those long-term side effects? Long-term side effects are anything that happens from 3 months till life. And that's chronic side effects. That's the vaginal stenosis or scar tissue, or any chronic bowel or bladder irritation. So those long-term increased frequency of urination or diarrhea or sensitivity to different foods. The risk of small bowel obstruction, the surgery and the radiation can cause scar tissue in the pelvis, and bowel can get entrapped in that scar tissue. So that is an increased risk with any treatment to the pelvis. Okay. And then there's a question about clear cell. I'm sorry to ignore clear cell carcinomas. Those are very important, high risk. They tend to recur locally or distantly. One thing that's important with clear cells is they don't respond to chemotherapy very well. So I also often end up radiating clear cells quite a bit. We like the Portec 3 regimen for these patients, where we do the chemo and radiation first and then do the systemic chemo, because often the systemic chemo isn't as effective. So let's do the radiation. These are responsive to radiation. So definitely something we think about, and clear cells tend to recur anywhere really. So we're kind of thinking about the whole body, but we do radiation for those pretty frequently. Okay.
Okay.
I think that's
Wow.
all I got.
You covered so much. I feel like we went to a class at UCLA.
You went to school today, and now I
Yeah,
will give you all homework, which is to follow up with your primary care doctors about vitamin C and no vitamin D and calcium, and also make sure if you've had a GYN cancer that you are getting your appropriate every 3 month or every 6 month exams.
yep. Wow. Thank you so much, Dr. Venkat. We really appreciate your time. And
Um, it's definitely my pleasure. Real quickly, I do not radiate the whole body. That would kill a person and should not be done. That's the last question.
oh my,
But I do
Well-
radiate all over the body, literally from the top of the head to the bottom of the foot and everything in between. I've done it. So it can be done. Really my pleasure. Thank you all for joining and staying. I will share resources as requested. If that would be interesting to everyone. I think the vaginal dilator protocol I've developed is unique and special, and I would love to share it with the group.
yes,
And then I'll think about other things and I'll send them your way.
that we would really like that. Thank you.
Awesome. Thank you
Okay.
all. It was a pleasure meeting everybody, and thanks for your time and attention. And I wish you all the best.
Thank you.
Your best. Thank you.
Thank you.